on the mouse thing? Hey guys, this you know, is a wickedly formal PowerPoint because I did it as like a grand rounds before, but it doesn't have to be. I much prefer interruptions and questions as we go because it would make it more pertinent. So, and I'm going to blow over a lot of the slides because I have slides that would last an hour, and I don't want to make you sit here for it that whole time. But sort of an outline of what we're going to do. We're going to go over the history, talk a little bit about biology of the tick and microbiology of the spirochete, talk about what Lyme can do, talk about a diagnosis, treat it, prevent it, and then I really want to get onto the controversy of it because I think the controversy comes from poor communication between us as providers and our patients more than anything else. And so us knowing how to communicate with our patients and sort of meet them at their symptoms will help us avoid any long-lasting controversy with Lyme. It's a fun disease. I really enjoy seeing patients with Lyme for the most part. And there's some issues where if I'm catching a patient too late, where they've already had a lot of interactions with Lyme specialists, I have a lot of catch up to do. But what my goal is in talking to you guys is trying to keep them in your all's practice and keep them from having to seek care at a Lyme literate medical provider where they will undoubtedly be immersed in potential controversy. So a little bit about the history. So by the way, when I see a patient with Lyme, I say, whenever they're done, I'm like, are you done? Because I want 10 minutes of your time to educate you on Lyme. And because I really do, I run over a miniature version of this grand rounds. I don't pull up a PowerPoint, I just do it in my head. So I say, hey, there was this arthritis that a rheumatologist described in kids up in Lyme, Connecticut back in the 1970s, okay? And it was clustered and they hypothesized that it came from a tick. And then a couple years later, they figured out it did come from a tick, the Oxoides tick, and they actually found out it was a spirochete was the etiologic agent. And since then, Lyme has bloomed into one of the most common zoonotic illnesses in our country. It's made its way onto, you know, the top of magazines. It's in songs. I don't know if anybody else is an Avril Lavigne fan like me. I'm not knocking her at all. I love her music. I got it all over my iPad. It's good stuff. But you know, she's got Lyme disease. I don't know what her serology looks like. I don't know if she actually has it or not. But she's got songs about Lyme disease. Lyme's cool to talk about. Steadily, the CDC reports about 30,000 cases a year, but there's estimates that it may be upwards of like 180,000 cases per year. Nobody knows, but it's common, way more common than any other tick or mosquito-borne illness that you may see in the United States. So everybody's going to see one. So I literally next launch onto stuff about actually a little bit about this stuff. So I'm like, all right, it's an animal disease that's spread to humans from a tick. Everyone blames the poor white-tailed deer, but it's really, you know, other small mammals that really act as the spirochete reservoir. And a tick is not born infected. A tick is born from an egg as you know, uninfected, and then becomes infected after its first meal. And it's really this nymph phase that's the danger. Now, I don't know if anybody has pulled one of these off of themselves or a patient, but no kidding, you know, when they say these are hard to see, they are downright impossible to see in anybody without the most like perfect complexion. They can blend in to the point where it really looks like a speck of dirt or a freckle or anything else. They say a sesame seed size for the nymphs, and that's true for the unengorged ones. And these are incredibly impressive. Not until I saw my first one on my daughter did I know how tiny these things were. And so really the unengorged nymph phase, which is the most common one that's going to transmit, they say is a sesame seed. I even think it's smaller than a sesame seed, truthfully. And then when they're engorged, it can be up the size of a poppy seed. The degree of attachment time, there are if you had a patient bring you in one, which I've literally had unfortunate folks who have a lot of tick bites who bring in a lot of them, and you can pull up pictures on Google to give you a degree of how long that tick was probably attached before it was removed. And you can tell from the degree of engorgement. And really what it's speaking to is that you need a prolonged attachment time for the tick saliva to transmit the spirochete, okay? And the insect vector is different on the East Coast or West Coast. The Ixodes scapularis is the one that we talk about transmitting on the East Coast. It's very interesting. If I have time and get onto it, one of the most fascinating things about this is you don't find Lyme disease everywhere you find Ixodes scapularis. And there's a little reason for that, maybe, that I'll get into at the end if I have time. But it's way more common on the East Coast and up around the Great Lakes. And this is a map that I pulled up, the most recent one from the CDC. If you go on the CDC website, by the way, they have a really cool yearly map that's updated from 2001 all the way up to 2017 is the most recent. And there's an awesome march of these blue dots from up here in New England, sort of up and over. We watched throughout the late 1990s, the march across Pennsylvania. And then in the early 2000s, it started surrounding West Virginia, and then has really infiltrated our eastern panhandle up in the part up near Ohio, Wheeling area of Mon County, southern. So it's really, we are now in West Virginia considered endemic. I have a couple old slides in here where I tried to say like that only parts of West Virginia are endemic. The truth is our entire state is considered endemic for West Virginia. I'm sorry, for Lyme nowadays. This is what ticks do. So I got to hang out with a tick biologist down in Charleston, and this is what he did for fun. And it was really cool. You'd go out and kind of try to catch ticks, and then they would study whether or not those ticks were, what their species was, number one. Then they'd actually do PCRs on the ticks to see if they were infected with the spirochetes. So they knew this was coming. The state health department was aware that Ixodes ticks were probably more prevalent in West Virginia, and they started finding Borrelia burgdorferi in it sort of before we started seeing clinical cases. So it was interesting that the bug people knew this and warned us ahead of time that it was coming, and it is. It came, and the degree of infected ticks is different across the country and across our state. By the way, this is what a tick does. They do something called questing. They go up on the end of a piece of vegetation and they sit there with their arms up. They don't fly, they don't jump, they don't chase you. They just sit there and hold their arms out and wait for you to bump into them, or they wait for your dog to bump into them or something, and then they can bite you and bury their mouth parts. And what we've seen, as I mentioned, is a spread across our state to the point where we really do have an endemic state now. And it's the small mammals tend to be the spirochete reservoir, which the early ticks bite and then turn into nymphs and then bite us. Why white-tailed deer get blamed so much is because they just allow the amplification of the tick population. So for everybody's always blaming the white-tailed deer, it's not the deer necessarily as much as just all sorts of mammals, etc. So, okay, so this part is unbelievably important. So if anybody wants to pay attention to like 5 minutes, the microbiology of Lyme, I seriously go through this with patients because everybody's like, I get it. This is awesome. I get it. I know why you're not worried, doc, and I know why I'm sick. Okay, so it's a spirochete. It looks terrifying. If you look at what it does, it looks like a giant serpent. And by the way, there's all these Google images that freak you out. It looks like Jaws. It like just zooming across, but you can't really see it. I can't see it under a gram stain or anything like that. It's too tiny. One of the coolest parts that I share with patients is this is a simple organism, and there's clinical sequelae to that. Look at this bug. It has a tiny little genome. Okay. Only 1.5 million base pairs, which I didn't know what that meant. I'm like, I don't know. Is that a lot or is that a little? So I put some other comparison organisms on here, and it's much simpler than things like staph and Pseudomonas, humans. Plus, then I got really excited to see what the most complicated animals in the world are. You know, amphibians. I guess you got to be pretty complicated if you can like turn from a tadpole into a frog. That's pretty cool. And by the way, the trillium, that thing that's like blooming all around West Virginia right now, is the most complicated. It has the most impressive genomic repertoire of any living creature. A trillium. I jealously went and stomped on them afterwards. I was like, yeah, take that, complicated genetic.
You're so pretty. You stomp on them?
I'm kidding. I don't really do that. So, and your genetic complement doesn't really represent like anything other than how many genes you have. But from why I bring this up and then share this to you guys is there's our clinical consequences of this being a really simple microbe First and foremost, this bug doesn't do much. It doesn't produce any toxins. Okay, so when I see a patient with Lyme, I ask them, have you had strep throat? And they say, yes, everyone's had strep throat. And I talk about strep throat makes you sick because it makes toxins and protease. It makes toxins that are physically causing this disease. The bug makes toxins which cause you to feel sick. You take an antibiotic and you kill that bug and you feel better promptly. This is much different than the pathophysiology of Lyme. Lyme makes no proteases, no toxins. The way it makes you feel sick is your own immune response to it. And as such, even after you kill the Lyme spirochete, you're going to have prolonged symptoms for a long time. That is, if you have one take home, that's it. The reason people don't feel better on day 1 or day 2 after you treat Lyme is because it's not the bug making you sick. It's your immune system that takes a long time to rev down. And so if you communicate that well with patients, don't expect immediately to feel better. Expect that you're slowly going to feel better as your immune system improves. That's going to be the first step to not having a miscue between patient and doctor. Okay, that's number one. The other cool thing about having a tiny genome is that it does not become resistant to antibiotics. This is hugely important. There are not, and this is a truism for spirochetes sort of in general. You don't talk, they're too simple unlike staph and Pseudomonas that we know can become resistant to just about anything they want. These don't have the genomic repertoire. They don't have the metabolic wealth to spend all their time becoming resistant to X, Y, and Z antibiotics. And so we don't talk about antibiotic failure because of resistance. And this is very different than what your patient will hear if they go on to a Lyme literate website. You know, Lyme is untreatable and hard to treat. No, it's an incredibly easy to treat microbe. Very true, very important. I always share that. So it's not the disease, it's not the bug itself making you feel bad. The bug's not hard to kill. The other bummer is we can't grow it in culture, so we do have to rely upon serologic testing for it. And anytime you deal with serologic testing, the concepts require explanation to patients. And so serologic testing, of course, having an intrinsic time delay until they're positive and potentially having long-standing positivity even after treatment are two things we have to communicate with our patients. I'll talk more about that again. I'm going to skip that one. So the natural history of Lyme disease is awesome, and I talked about Alan Steer's first description of this cohort of patients, all those people with arthritis that he described in Connecticut. They could very nicely describe what happened. They had, you know, erythema migrans, local dissemination to various organs. But the part that never got any play is that eventually everybody got better. I share that on the first visit with patients. Guess what? They didn't know what it was in the 1970s. They followed these patients for a decade. Everybody got better. Nobody died. That's an incredibly important message to share with your patients. Everybody gets better without treatment. We don't want you to feel sick for a decade, so we will treat you and you'll get better quicker, but not necessarily overnight. Okay, so you do have eventual immune clearance. You can get reinfected, especially if you get treated too quickly before you have an immunologic response. I share this information. The people don't die of Lyme disease. That's almost a true statement. A couple people have died of Lyme disease during the early cardiac involvement. By the way, cardiac involvement always passes, always goes away on its own, with or without treatment. But unfortunately, it is potentially involved with heart block. And as such, heart block can be fatal. And you can see in the statistics that this evaluation done about 100,000 people with Lyme disease and 1 death, and this was from cardiac involvement of Lyme, which is self-limited and goes away. So I try to share that with people. Hey, you have a disease process that is easy to treat, and even if we don't treat it, it'll go away and it won't kill you. All right, good. So we're all on that page. Clinical manifestations. I like this line. Precision of language is really key when we communicate with patients about Lyme, because Lyme can do a lot, but Lyme can't do anything it wants. And so there's a misnomer that Lyme can do anything. No, Lyme can do a lot, but they're really distinct syndromes. And as long as we describe them and put them in categories, it'll help us make sure we understand, does the patient fit Lyme disease, a known manifestation of it, and how do we treat it? Because it's sort of dependent upon the stage at which we diagnose, et cetera, what we do. So, and think of syphilis. So we have the early localized rash, early disseminated disease, which we'll go over, and then you can have late manifestations of it. And then I want to get on to what the post-treatment Lyme syndrome is. And by the way, it is something. It genuinely is. So you're not going to hear a naysayer here, but I'm going to give you an educated opinion of what it might be. All right, so the E. migrans rash, everyone knows that it's a bullseye, but the reality is it's seldom a bullseye. It tends to be a round, reddish thing. That's it. You just need something that's roundish and reddish, and it bigger than 5 centimeters makes your confidence higher. Okay, I've seen this look like all sorts of stuff. It could even be vesicular. I've mistaken it for early herpes or chickenpox outbreak, so or shingles. So you can look like all sorts of stuff. Okay, but what you're looking for is a general ovoid manifestation expanding with time. If you're lucky enough to catch it looking like a bullseye, that's great, but a lot of them don't look that way. Okay, the differential diagnosis of it, the most common and important thing to differentiate is an insect bite hypersensitivity. So the tick bites themselves, a lot of people are allergic to tick bite saliva, and you can get a local sort of erythematous ovoid rash immediately after a tick bite or shortly thereafter. But if it's too soon, it's probably not E. migrans. Okay, so remember the incubation point for E. migrans is usually about a week out. I've seen it just a couple days out. I've seen it over a month, almost 2 months out from a tick bite. But too early on is probably not. It's probably a hypersensitivity. Cellulitis is a real common misdiagnosis, and the only thing that sort of goes against routine cellulitis is the distinct ovoid shape of E. migrans, as opposed to the more nebulous diffuse erythema of cellulitis. There is a perfect mimic of erythema migrans called stari, which is literally, we don't know what it is, but it's some infectious, some tick-borne infection that looks just like E. migrans, but doesn't seem to have any of the late sequelae. It does not seem to have any dissemination. It just presents as sort of a local E. migrans type rash. It comes from a different type of tick. Nobody knows if it's a spirochete or what the heck it comes from. But the local symptoms, I'm sorry, the E. migrans can be accompanied by a flu-like syndrome. Absolutely can have a flu-like syndrome with a predominance of headaches and muscle aches and pains. Okay, so it can really present as the flu-like syndrome with fevers. If you have a ton of fevers, remember that the Oxoides scapularis likes to co-transmit some other microbes, most importantly, anaplasmosis in our area. We don't have Babesia that I've seen. I can't speak with certainty on that, but I've never seen Babesia as a co-pathogen in our area. But it's certainly the Oxoides scapularis has that potential to transmit it. Maybe we'll get Babesia one of these days in our area as well. But keep that in mind if you have a fever. Anaplasmosis doesn't really matter because you're going to treat the patient with doxy, and the anaplasma is going to get better anyway. Babesia requires an azithromycin-based derivative, so if you had someone who didn't respond, maybe think about that one. During the early parts of Lyme, sort of after, if you didn't treat it at the E. migrans phase, you can sometimes catch people with like a couple E. migrans, and these can be multiple to many. So you can have them all over the body. You can have Bell's palsy as part of early disseminated disease. You can have early neurologic involvement, such as meningitis, a genuine lymphocytic predominant meningitis. And I'll talk about those. So a lymphocytic predominant meningitis. You can get really, really weird radiculopathy that seems like somebody's blown a disc, okay? So, and this really seems to be, I've seen it both upper and lower extremities, but of late, the most common complaints that I've seen consistent with Lyme radiculopathy have been bilateral upper extremities. Seems like they have a C-spine disc out, okay? Again, this is not in and of itself just alone. This is in the setting of a recent flu-like illness, migraines, headaches, etc., but part of the early disseminated disease. It's well described also being in the lumbo and sacral areas, but I've seen more than a few upper extremity cervical radicular pain complaints. I mentioned the carditis already. So as part of the early disease, tends to be a few weeks in, you can get heart block, present with syncope or near syncope or cardiac manifestations. The good news is it goes away. The bad news is sometimes you have to spend time in the hospital with a temporary pacemaker, but it goes away. The late manifestations of Lyme tend to be predominantly neurologic or arthritic. The arthritic late Lyme is really interesting. It's not arthralgias. This is not, I heard all over, this is a distinct, usually effusion predominant arthritis. So, and what I mean, this picture up here, I put it up here because honest to God, that's exactly what it looks like. It's not red, it's barely warm, it doesn't look like a staph infection of the knee or elbow. It looks like a balloon. It looks like a recently traumatized joint. And the knee is by far the most common. It's usually one-sided, and very often the patient will give a history of recurrent episodes, like 1, 2, has had multiple episodes. It can be other joints as well, as you say, and that's what they describe as asymmetric and oligoarthritis. That's a lot of big words. That picture says it better. Okay, swollen, intermittent, or persistent with eventual resolution. Okay, but it can last a long stinking time. Okay, and so it's something to be aware of. The late neural, oh, and by the way, is important. Some of this Lyme late arthritis can take on a life of its own. So even after, there seems to be a certain HLA-DR4, if you're unfortunate enough to have a certain HLA type and you get infected with Borrelia burgdorferi, your body can trigger an autoimmune response, and you can have an autoimmune arthritis that does not respond to antibiotics. So absolutely can become antibiotic refractory. It's very unfortunate. The only good news is that most of the time burns out as well. Most of the time burns out. The late neurologic manifestations tend to be, the ones that are most well condoned are non-structurally explained peripheral neuropathies, such as radiculopathy. So in other words, if you see a patient who's a really outdoorsy person who's coming in and or has dogs and cats who sleep in their bed or whatever, who comes in and complains of what seems like sciatica, and yet their MRI is negative, consider testing them for Lyme, okay? Because it can present as a spinal radiculopathy or any other neuropathy. The more debated diagnosis is this subtle chronic encephalopathy that I currently suffer with, and most of us suffer with on Monday mornings, but I think it's real. It's a subtle dysfunction of the CNS that makes us unhappy with our cognitive status, also known as caffeine withdrawal. But no, but I genuinely believe it. I've known too many normal patients now who get this and just don't feel like their thinking is up to par. And who am I to disprove that? I think it's probably true, and it's accepted in the literature. There are some people, especially during the acute phase, who demonstrates white matter changes, almost like MS. So there's something to it, okay? But this is accepted. By the way, oh, good old G-Dub, okay? This was the coolest thing ever. You know, apparently, if you were a Democrat, by the way, George W. had Lyme disease, or at least had migraines rash. I didn't know this. When he was president, he had one. The Democrats said, man, he's got Lyme disease, without a doubt, because of the subtle neurocognitive changes. Okay, the Republicans called it STARI, the Southern Tick-Associated Rash Illness, because they're like, no, it was just migraines without any dissemination. I just thought this was fascinating, that there was a tick-borne illness debate that took, of course, political sides. I'll give you my own opinion later on that one. But so anyway, you can, if we talk about ways to really remember what Lyme can do with migraines, that chronic arthritis, again, can you get diffuse arthralgias from Lyme? You sure can, but it's during the acute phase when your cytokines are revved up during that initial ILI, during that acute influenza-like illness. But the late arthritis, the oligoarthritis, swelling of the knee or ankle or elbow, etc., is what we're talking about here. Bell's palsy, the non-structurally explained radiculoneuropathies, and acute lymphocytic meningitis, the chronic or encephalitis, and then carditis. This is really what it can do. I'm going to make diagnosis really easy. You do basically, you want to test somebody who has one of these manifestations, okay? So test somebody who might have one of these things, not just population screening. And it is a decent test, okay? Basically, all we ever run on patients is serology. We don't try to culture it. The PCR, don't order it. It will confuse you. It's seldom helpful unless you're an orthopedist. If you're an orthopedist who has ready access to synovial fluid, you can run a PCR. Otherwise, it's not useful on other body fluids. I've not had it be helpful. Okay, so just run serology. Okay, and the serology to do is just that. Well, I'll get to it in a second. But the issues with any serology is if you check a serologic test too early, it can be falsely negative. And too early means if you check in the first 30 days of symptoms, okay? So in the first 30 days after a tick bite, you don't have 100% confidence in the test. So sometimes you will check a convalescent serology, and we'll talk about that in a second. Some things can cause false positives. You know, I think we all are familiar with the concept of a false positive RPR. The RPR is the classic screening test for a spirochete that we know is not diagnostic necessarily of syphilis. Same thing for a screening test for another spirochete, Lyme. It doesn't always mean you have it. There are false positives. So you only want to test in the correct clinical setting of one of those clinical syndromes. But the test performs really well. It really, really does if you test in the appropriate clinical setting, okay? So somebody with symptoms consistent with Lyme, all right? The testing is pretty simple. You order a screening ELISA. If that's positive, that's like the RPR, ELISA, it goes for Western blot. And the Western blot, unfortunately, requires a bit of our interpretation at the level of a clinician, in that we only want to look at certain parts of the Western blot depending upon how long the patient's had symptoms. If a patient's had symptoms for less than 30 days, feel free to look at both the IgM and IgG. If they've had symptoms for more than a month, only look at the IgG. And the reason for this is the IgM suffers from a lot of false positives, okay? If you have genuine untreated Lyme, the conversion from IgM to IgG tends to be robust and very convincing. This doesn't tend to be a subtle diagnosis with 1 or 2 bands of IgG positivity. It tends to be 5, 7, 10 out of 10 bands for IgG. So this is something that, as we're interpreting it, the first question we must remember is, hey, am I testing this patient in the right clinical scenario? Yes. And then how long have they had symptoms? More than 30 days or less than 30 days? And if it's more than 30 days, try not to focus on the IgM as much as the IgG. By the way, you don't have to be a total purist on this. There's room for interpretation. You know, if you got somebody who you're very much convinced had a lymphocytic meningitis from Lyme and they only have IgM positives and it's 6 weeks out, it's okay. You got the diagnosis. You know, there's some wiggle room here, but these are general concepts that if you have not treated Lyme appropriately, the conversion from IgM to IgG will occur, and you can trust those tests. That makes sense? I hope. Okay. So other things to know about it is you cannot, remember for syphilis, you trend the RPR to know if you had treatment success. So say I have somebody with syphilis and their titer is 1:64, and I treat them with penicillin or doxy, and I follow them up in 3 months, and their RPR is markedly improved. That means I did good. You treated the patient, it was successful. The same does not happen with Lyme, okay? So you cannot, unfortunately, trend anything. This is a huge cause of patient confusion where they quote, Lyme tests are still positive. that's a compliment to their immune system. And I always try to say, like, good job, bro, that's awesome. Congrats, man, you got a great immune system. And I don't really say that, but in my mind I do. So I try to tell them that this is, explain serologic based testing, and the fact that their Lyme testing is still positive is okay. Now, that being said, I love to document multiple Lyme serologic tests so that I can be aware of potentially untreated or undertreated Lyme or potential reinfection. So if you have a patient that you diagnose with Lyme and you treat them, the books will say you don't necessarily have to relook at their serologic status. I like to document multiple times what is happening with their serologies. This is if you've truly diagnosed Lyme, because it can give you a sense of if you have a unbelievably expanding repertoire of Western blot bands. And what I mean by it, so Western blot bands come back as a list of how many out of 10 IgG bands you have positive. If a patient was doing great, and I shouldn't say if a patient had ongoing symptoms and comes back to you and they initially had 5 out of 10 Western blot bands positive, and comes back 2 months later and they're still suffering from terrible arthritis and a lot of axonal radiculopathy, and now they have 10 out of 10 bands positive, I would question that maybe I didn't treat them adequately. So that's what this beware of expanding repertoire of Western blot bands means. And so I do tend to document it multiple times in the patient's care, what their Western blots look like. Hope that makes sense. Okay. And you can use some alternative modalities to help diagnose, especially neuro-Lyme. Sometimes you can see white matter changes in MRI. Sometimes there's CSF abnormalities, but people seldom want CSF evaluated. EMG can be helpful. So I a lot of times I use my neurology consultants to help me do EMGs and MRIs to make sure that there's nothing else going on. Just like, I'm gonna do a one-liner on this one. It's just Lyme is a notifiable disease. So, and I don't think I was doing a very good job on this previously until I met the director at the health department who told me I need to do a better job on it. But if you do see patients with Lyme, feel free to fill out the form on the West Virginia IDAP page. It's WVIDEP, the West Virginia IDAP page, and make sure they get adequate numbers. The punchline of this is we now have an endemic country or an endemic state. That's all I'm going to mention. Treatment. There's the various options you have are all the drugs I have listed. So you can use doxy, which I like because it treats copathogens. You can use good old amoxicillin. You can use a second generation cephalosporin. What you can't use up here is a first generation ceph. So one of the things that, if you had cellulitis in your differential, Keflex is still a good drug for cellulitis, but you remember, if you're at all entertaining E-migrans, kind of avoid the Keflex because it's not going to treat a spirochete. So doxy, amox, cefuroxime, or that's pretty much the three I think of. If you wanted to do IV stuff, the third generation cephalosporin, ceftriaxone and cefotaxime are fine, and penicillin. We generally use ceftriaxone because it's so much easier, once a day, and no renal adjustments. And the duration depends upon really what the clinical manifestations are. The times when we go to IV treatment is when you have CNS or neurologic disease. So radiculopathy or concern for CNS disease, including meningitis or encephalitis, you can go with IV treatment, usually for 28 days. Cardiac disease, they're usually in the hospital for this one, and you usually treat them with IV ceftriaxone until their AV block goes away. Then you can switch into PO doxy. One caveat I want to mention about arthritis. Arthritis is probably the only situation where retreatment, in other words, an extended treatment course, is condoned. Okay, so if you have somebody with a single swollen joint or a few swollen joints, and you treat them with doxycycline, they get better, and they come back still with symptoms, feel free to retreat them. You could retreat with doxy, or you could go to IV therapy. So the only Lyme syndrome that we routinely treat for longer than 28 days is arthritis, and you treat for a couple distinct courses of 28 days, or IV, okay? Otherwise, the migraine stuff you tend to treat with a short duration, 2 weeks of doxy, and everything else you tend to treat with shorter courses. Okay. I talk to patients about this, that recovery may take time. Okay, so you can talk about weeks to months till people feel better. Oops. And that's a really important thing for you to communicate to your patients. And again, we understand the microbiology now because it's not coming from a toxin production. This is coming from an immunologic response. And it takes time for that immunologic response to ramp down. Okay. It's a spirochete, so apparently a Herxheimer reaction can occur. Remember, this is like a transient worsening of symptoms when you initiate people on antibacterials. You can see this with intracellular pathogens and spirochetes, but I've not seen it, but the Lyme literate medical providers have really hung on to this concept, and I'll go into what I mean there in a second. I'm going to skip over prevention, other than you can dress really cool to try to prevent ticks. But you know, I do preach to patients about DEET on their skin and permethrin on their clothing. You know, it's scary. Ticks are scary, and if you've had Lyme disease, you're terrified of the ticks at that point because it's really devastated your life often for a short time period. And so prevention of repeat bites is a huge thing. So talk about DEET on the skin, permethrin on the clothing. There is post-exposure prophylaxis. If you have somebody who had a tick bite with an Oxoides tick that's not removed promptly, you know, you can give them doxycycline. Okay, so if you have a tick bite, you can give somebody 200 milligrams of doxy. I have very frequently given people who've gotten through their Lyme treatment a prescription for doxy and let them just have it at home in case they need it and take their 200 milligrams times 1. If you're doxy allergic or can't take doxy because you're a kid, you're out of luck. You know, there's no treatment or no information on using beta-lactams for post-exposure prophylaxis, okay, if you're pregnant or something like that. There was a vaccine that was out from 1998 till around 2002 or 1 that dogs can still get, by the way. You know, pets can get it. We can't as humans. We can't as humans because we can hire lawyers. So, so this is a absolutely fascinating history. The Lyme vaccine was okay. It wasn't great. It had like 70 to 80% efficacy. The more shots you got, the better it worked. It didn't last for a long time, maybe a couple years. But there was a lot of controversy over concerns about potentially inducing autoimmune arthritis. There was a lot of post-marketing safety analysis that said that did not happen. But there was a big FDA sort of get together in 2002 or 1, I can't remember exactly, and there was a decision by all involved parties to withdraw the vaccine. There was a lot of impending lawsuits that people felt like they were getting arthritis from the vaccine. There was at least some truth that molecular mimicry could occur. Okay, so the vaccine maker decided to take it off the market. That being said, there's no evidence that, I think the fact I read, there was of 1.2 million doses delivered, there were 59 cases of arthritis, and that rate was exactly equivalent to the background occurrence of oligoarticular inflammatory arthritis. So no one knows if there's causality. But anyway, the punchline is that we can no longer give it. We don't have it. Okay. And by the way, I just love these things. So, I literally tell my patients, I'm like, go get some guineas. Go buy guineas. The other thing you can buy is possums, but I don't know how to buy possums. So you can buy guineas. And this is an awesome trial. If anybody wants to read this, it's the best thing ever. They had a yard with guineas and a yard without guineas, and there's like, this was the conclusion some smart doctor wrote. I love this. Several drawbacks. Noisy and maybe objectionable to human neighbors. Their droppings may be unpleasant. I don't know many creatures that's not a truism for. It says, on the other hand, droppings may discourage humans from sitting on the ground. See, if I got to write papers like this, I'd probably be an assistant professor by now. But anyway, I've told my patients to get some guineas and stuff like that. But the controversy of Lyme comes from this thing, this post-treatment Lyme disorder. And this is a fact. People don't feel great after getting Lyme. I'm scared of getting Lyme. I know all about it, and I'm scared of it. Why? Because you don't always feel better after you get it. True statement, okay? The first thing we need to do is meet our patients halfway. And if you've actually had Lyme, and accept and talk to them about this fact. Some people can take a long time to feel better. I tell them about 20% of people don't feel great still at a year. So that already gives them some credence that, man, this is okay. I'm going along with what medical practice accepts. What symptoms might you have? You just don't feel good, some pains and aches, maybe brain isn't working as perfectly. And this would suck if you were going along happy with your physiology and then suddenly you got a tick bite and then this happened, okay? So I totally have huge sympathy for people who've had this stuff. And I try to say, I believe you. I definitely believe you. There's a few caveats to that. I want to make sure you don't have something else. Okay, so you have to be really careful not to have false attributions because patients, a lot of times, once they've had Lyme, they want to think everything they'll ever have for the rest of their life is Lyme. And that's part of what we need to do as doctors is make sure that, yes, you had Lyme. Yes, you might still feel poorly, but let's make sure you don't also have leukemia or multiple sclerosis or something else terrible that we're falsely attributing your symptoms to Lyme. Okay, so, but I try really hard not to naysay. I try to jump on board and say, yeah, you're probably right. You don't feel great. The problem with post-treatment Lyme is we don't have certainty of what causes it. The assumption is that this is from a slowly resolving, robust immune system inflammatory response. Okay, so it just takes time to improve. There have been, and by the way, I disagree with these studies. There are a lot of people who want to simply say that post-Lyme disease syndrome is an anchoring bias and that people simply feel like aging Americans then. And they want to blame all their symptoms on their past tick bite. I don't like this. I don't find this fruitful or helpful. And it is a great way to alienate your patient. So not helpful. I don't tend to go there. One of the things we do need to make sure before we label someone with post-Lyme disease syndrome is to make sure they had Lyme disease. That's a must. So have to make sure, and Dr. Steer, he's the guy who described as the most common reason. He said people didn't get better after having been diagnosed and treated for Lyme disease is because they never had it. True, I wouldn't expect you to get better then. But post-Lyme disease, you have to have documented Lyme, okay? And you have to have resolution of the objective manifestations. And what that means is your heart block went away, your meningitis is better, your facial droop improved, you no longer have e-migraines, but you still don't feel good. Fatigue, widespread musculoskeletal pains, complaints of cognitive difficulties. Okay, this is what would be post-Lyme disease. Here's the problem. There have been 4 randomized placebo-controlled trials giving people more antibiotics, and it doesn't help. So the genuine problem we have as a medical community is we can say, we believe you, patient. I do think that you still feel poorly, but I have nothing to offer you other than explanation of the natural history and an understanding that you will get better, but it's going to require patience. Now, I found that's incredibly helpful. The whole, you won't die, that's always good. You will feel better. You'll feel better quickly than if we hadn't treated you. And please be patient and understand that you're still improving normally, that it's okay that 1 in 5 still doesn't feel great at a year. This very often prevents people from doing something harmful to themselves. The problem is, without that communication, by the way, I spend about an hour with my Lyme patients to talk to them about this stuff because it requires education. Otherwise, what happens is they leave your office and they go to one of these other people, a Lyme literate medical doctor. Despite the fact I just spent an hour telling you guys about Lyme, I am not a Lyme literate medical doctor, okay? An LLMD is someone who believes that Lyme can do anything. Absence of precision of language, okay? they believe, and I call it a belief system, that the Lyme is from active infection, ongoing, that a lot of times there's other co-infections that we can't test for, that routine tests are not reliable, and that you can easily treat Lyme, that Lyme is nearly impossible to eradicate. Okay, this is the belief system of a Lyme literate medical practitioner, which goes in complete concert to everything I've talked about. Okay, so remember, we preach that it's not from active infection, it's from slowly resolving inflammatory process, that we can trust our testing, and that we can very easily eradicate the organism. So very, very different. There's definitely a logic paradox to the Lyme literate medical provider's thought process. There's various solutions that the Lyme literate medical provider has to most protests I have, such as they use their own tests. They send the same serology, but they send it to a lab, I'm going to use the name IGeneX, that tends to have a much more frequent positive test results. And it's not that the test's different, it's this, they interpret the test differently. So different thresholds of positivity.
Have you ever seen a negative one?
I have actually, yeah. Remember, they only require like 1 or 2 Western blots to be positive. So yeah, and then the other concept is the Lyme literate medical providers have invented a disease called chronic Lyme. Chronic Lyme is seronegative. So in other words, it never was Lyme, never was Lyme. It's basically someone who probably has one of these other diagnoses, chronic fatigue, fibromyalgia, depression, blah, 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 blah. But you can call it Lyme if you're a Lyme literate medical provider. Okay, so I'm trying not to be negative. I actually have a friend who's a Lyme literate medical provider, and he believes he's helping patients, and I don't hate him or anything. But, I love that, I'm not one of these because I've not donated, but find your Lyme literate doctor. I don't show up. I love the big donate sign here. This is what Lyme literate medical providers have in their armamentarium. A lot of drugs that don't kill spirochetes. I don't know what they're using antimicrobacterial drugs for, or antivirals, or antimalarials. I don't even know how you get artemisinin in our country, and yet you can. And then other interesting things like giving immunoglobulin, hyperbaric oxygen, using ultraviolet light or hydrogen peroxide or electromagnetic rays on the blood, giving people malaria, because fevers does kill spirochetes. So all sorts of interesting things that you can get done. This is one of my patients. I put this up here because a list of what her Lyme literate medical provider was giving her: doxy, ceftin, doxy, zithro, rifampin, doxy, Bactrim, artemisinin, flagyl, mepron, flagyl, artemisinin. By the way, her only complaint was nausea and yeast infections. Done. That's and the logic behind the Lyme literate medical provider is, hey, you're doing great. Hey, this is working. If you're having a bad day, oh, it's because we're killing so many spirochetes, you're herxing. You're having a Herxheimer reaction. This is now in the lingo of people who suffer from Lyme. Okay. And then, oh, you're just not getting any better. We need to add more. And I've seen innumerable patients with this. So and by the way, what happens? The scariest and most concerning thing that happens is false attributions and misdiagnoses. So people who once had Lyme disease, then forever. And by the way, we doctors are at fault to a huge degree, because we tune out when a patient comes in with their Lyme and we're like, oh gosh, because they're going to tell us that it's all from their Lyme. Our job is to listen to the symptom and come up with a differential diagnosis that's not Lyme. I truly think that's our job, because there's been, the CDC has a whole bunch of case reports of things that have been missed because a patient is attributing to Lyme. There have been absolutely direct toxicities from these medications and various things. C. diff, line infections. There's even been deaths. Deaths from C. diff and fungemia, and of course from the misdiagnoses. Okay, but the most amazing and astounding thing about this is, shouldn't something be done? I'm sure we all find this page astonishing. But so the CDC, I'm sorry, that the IDSA, sort of my professional society, they came out with nice guidelines that tell us how to treat Lyme. And what happened at a societal level was protests against these. And in fact, our own government, the Attorney General of Connecticut, now US Senator Blumenthal, sued the IDSA and said that, well, this shouldn't come as a surprise, that the scientific-based guidelines are not accurate, and that we need to support more the Lyme literate medical approach.
Does that not seem like snake oil medicine?
It is snake oil medicine.
LLMD.
But if you go to the LLMD advocacy groups, they use great lingo. They use stuff like we believe in a patient-centered approach, individualized. We believe in clinical judgment, quality of life. So I was reading these and I felt terrible about myself. Apparently, as a traditional medical practitioner, I have none of these things.
Patient-centered. But they're feeding on fear.
Sure, absolutely.
Patient fear.
Do know at West Virginia level, we recently got added to the state laws protecting the Lyme literate medical provider. I don't want to encourage any of you to go out and buy a UV machine or start giving people malaria. But if you do, you can't get sued. That's pretty cool. But basically, the laws now are on the side of the LLMDs. Very interesting. And again, the patients tend to really support their doctors. And again, it goes back to that concept that I don't have much to offer them besides education. But done right, education's powerful. And you spend an hour with your patient, a lot of times you get them to buy in, okay? It's a disease politicized and it's a disease stigmatized. I feel bad for the patients, I really do. But if we understand the basis of the microbiology, the limitations of our treatments, the expectations for improvement, and use precise language, we can go a lot further to eliminate this controversy and keep people out of the hands of the LLMDs. By the way, LLMDs, including my friend who does it, it's not cheap. You know, people pay cash. It costs a lot of money. You can understand why people could fall into it, though. By the way, I thought I could look this one up and figure out an answer of why Lyme. I was like, man, it should be an answer. But you know what I came up with? I think it's because it's Americana. Like, it's cool to get Lyme. You know, you can get it on your John Deere tractor. You know, you can get it from your dog. You can get it from skinning the deer. You know, there's been a spirochete for years that can give you all the same stuff, but to get it from dirty sex. So, you know, we don't talk about that. Nobody's got there with signs, you know, cure my syphilis, stuff like that. But you know, Lyme is Americana. You know, it's okay to get Lyme. It's kind of acceptable. But this is really the stuff behind it, and the controversy. But this is fear, ignorance, in the internet. You know, is really expanded the mythology of Lyme's properties far beyond scientific fact. So, but I want you guys to understand where the controversy falls in, the limitations of our approach, and you know, why your patient might fall prey to some of this quackery and snake oil salesman-ishness. So, fire away with questions.
Not too shabby, John. I like that.
We are a little over time, so I'm going to
sorry.
close this. It's okay. No. We do have some questions, though, so I'm going to get to those real quick.
Yeah, regarding prophylaxis.
Yeah.
Yeah, the doxycycline treatment. I mean,
200 pounds. Yeah.
Should we just go ahead and treat patient when they are giving reliable history, they are bitten by tick, because now we are an endemic state. So we should just go ahead and treat them.
You know, the last time I talked to the people at the state health department, they tried to keep us limited to those in the eastern part of the state, eastern panhandle. But I've been doing it now. There's too much. I don't know of, the CDC has a stupid guidance that says if greater than 20% of your ticks have a spirochete. And I'm like, yeah, I don't know the answer to that one. So to answer your question, yes, I have absolutely been doing it. Yeah, if somebody gets tick bite, I'm giving them 200 milligrams of doxy. It puts their mind to bed and it makes them feel like you're hearing them. And 200 milligrams of doxy hurts almost no one.
Yeah, thank you. Thank you. Excellent presentation.
Yep.
No, thank you all.
Dr.
Oh,
Leonard.
go for it.
Yep. So what about me? What about the kids? I mean, we've shown doxy's not as
What
bad
about the
as
children? That's right.
That's right. What about the children? They're getting lost in the opioid crisis. They're getting lost in everything.
The scariest thing with the kids, you always learn best from selfish reasons. And, after my daughter got bit, I read everything I could read about trying to use a beta-lactam for post-bite prophylaxis, and there's literally nothing written on it. And there was even a couple articles that suggested even mechanistically didn't make sense to do it. Because so the sad thing with kids is, like, post-bite, it's literally you have to watch for the development of migraines rash. It sucks. It really does suck. Kids are the challenging part. They really are, because they're also so prone to it. I mean, they're out all the time outside. But no prophylaxis is, and again, me not being a pediatrician, my training had always been incredible discomfort with giving kids doxy.
But the newest stuff doesn't really support that, though.
Right on, especially a single 200 milligram dose. Right. I think you're fine. Now, what would my threshold be? Man, hopefully they save the tick and show it to you that it's noxoides, or at least by description, they can tell you it was a poppy seed size. It was itty bitty.
Right.
I think in that scenario, remember, a lot of the ticks that bite people are dog ticks, and
yes,
they're not going to be a concern. And so I would not bother prophylaxing anybody with a dog tick bite for a kid. But if they come in and give you a description of something that looked like a little speck of dirt and they pulled it off and had legs, I wish I'd asked Dr. Moffitt or one of our pediatric people ahead of time, but man, their threshold for giving people doxies, they don't tend to worry about it. They tend to do it.
Yeah, right. And that's been my experience when me or one of my other providers have, like our PAs or something from the walk-in have called.
Yeah.
That's been the recommendation.
So as opposed to what Dr. Pollywall, where I was very liberal, I said, heck yeah. I go to almost every adult. You saw a tick, here's your doxy. No,
here's your doxy, yeah.
It's a little bit different for a kid. At least I try to make sure it's an oxoides tick.
John, I think you're a better doctor, but also a better father than I am, because my son last year, he was almost just right at his 9th birthday, had this great big lymph node.
Oh no!
On his neck. Yeah, it was a great big lymph node, and I took a look. And I was like, oh my god, what in the hell is this? And he didn't feel bad or anything, but and I took him in the bathroom and was looking at his head, and he had this big engorged tick on his head, right? And I didn't think anything. I was like, oh god, nasty thing. Like rip this thing off of it, murdered the tick, right? And then like the next day, his lymph node was better, and it was decreased in size. I was like, all right, he's fine, no big deal. So I don't know, 4 weeks later or something, he comes over to me and he goes, Daddy, my arm hurts, right? And his wrist, like he had this really swollen wrist. And, 9-year-olds are not supposed to have arthritis. Like old people like me, have arthritis, that sort of thing. And so I asked, I told Dr. Leonard that, before he called CPS, he ought to look and stuff, right? So we decided, well, we'll go ahead and, we'll put him on doxycycline. We'll go ahead and treat him and see how it does, right? And so he takes his first dose of doxy. And I think it was maybe 8 or it was probably closer to, 16 hours later. I mean, he was sick as hell. I mean, really sick, sweating and had rigors and chills and all this stuff. So my wife called me and said, man, that is so freaking cool. Like that's awesome. My kids got the Herxheimer reactions. This is terrible parenting. But, I was like, man, maybe that is. But literally, he was better. Now, who knows for sure, if it was something else or, there's all sorts of reasons why. Doxy cures a little bit of everything. It's got good coverage. So it could have been anything as far as that goes. But for what it's worth, too, dogs actually get the Herxheimer reaction. Wow. My dad is a veterinarian, and I grew up in a heavily endemic region of Maryland, on the eastern shore of Maryland, and dogs, particularly in Delaware, that would come and see Dad, that sort of stuff. I mean, you saw tons of it, and Dad said, for what it was worth, I was supposed to tell you that Labradors and Cocker Spaniels seem to get the Herxheimer reaction more than other breeds of dogs, for whatever that's worth. I mean, nobody has any idea, or at least my dad has no idea why that would be, other than the fact that it seems to happen. But what's interesting is, at least in veterinary medicine, they weight-based dose the doxy that they give when they treat dogs for Lyme disease, and it's a much higher relative dose.
Wow.
And I don't know why that would be, other than the fact that they weight-based dose everything in veterinary medicine. And I mean, a 200 or a 100 milligram twice a day dose of doxycycline for a 200-pound man like me, I mean, is like almost nothing compared to what's used in veterinary medicine. I have no idea why that is. I mean, I've never been smart enough to understand why it is that we don't have to weight-based dose medicines in human medicine. Once we're real humans, and not children anymore. So it's, but it's, I don't know. I mean, just for what it was worth. I mean, I don't know if what he had was the Herxheimer reaction or not, but he definitely got that. I mean, he did really well, and for what we can tell, he has no post Lyme syndrome or anything. I mean, he's a normal 10-year-old now. But
there's a lot of people who don't get that stuff, that post Lyme, but it's I've seen enough people that I would qualify as just standard citizens who do get that afterwards, and I've become a believer that you can get better slowly. Truly do. Just do nothing. But dude, that's awesome. Cocker Spaniels and Labradors. I probably will never be able to forget that now, by the way. It's stuck in here now.
for whatever it's worth. I mean, it's not worth anything other than mentioning, and I always do. So it's just kind of a, it's one of those things that people, Cocker Spaniels and Labradors. I'm like, and I have clinically diagnosed, I think I have diagnosed and then confirmed with serology 3 cases of Lyme disease, not counting my own kid that I met like by a mile, but it was
Lyme testing. Did your son get the serology? Did he do it?
I'm sure not. I mean, I'm just like, as I think about it, just because I'm a worthless father. Like I pride myself on being a reasonable doctor and a really terrible father. My wife always says, she said, doctors' wives die young, and I'm like, this is why you never think any of us ever have anything. I'm like, yeah, it's not real. You're fine. Sew it up. It's gonna be okay. But,
oh my God, I love it. I love it.
All right, guys.
So I have one more question, unrelated.
Yeah.
Quickly. I was talking to Dr. Eric Anger out of Elkins, and he was talking to one of the wildlife biologists in the Elkins area and talking about chronic wasting disease in deer.
Yeah.
And that biologist had estimated in the not too distant future, no more deer hunting due to chronic wasting disease. Are you hearing anything like that on your end yet, or
not in the medical literature, but in the so yeah, I pay attention to a lot of in the veterinary world too, just for fun and sort of like the fish and game stuff, because what my parents are wildlife rehabbers. That's kind of what they do, and so yeah, that's been on the radar for a while, and certainly expanding and getting pressed, but nothing. That's terrible, by the way. I didn't know we had it in West Virginia. Heavy.
Eastern Panhandle, for sure. It's not that heavy, so I didn't understand where that was coming from, because I watched for.
Is that the
avid deer hunter?
Is that the prion disease? Is that right? Okay.
Yeah.
That's like the spongiform encephalopathy thing or whatever. I see.
Yeah, I mean, because I'm an avid hunter and we eat them.
Yeah.
So, it'd be terrible to lose that as a source of fun as well as a source of food. But
and then God, what's that going to do to the Lyme if people aren't killing the deer? They're going to go crazy. Yeah, no doubt.
And that guy was right, by the way, about guinea fowl. They really are annoying. Like they are shrieking horrid things. Like there's no, you're not going to sneak up. You're not going to rob a house undetected with guinea fowl in the yard. They are, it's awful. Like they are, he's, I don't know about the droppings and sitting on the ground or anything, but it's, that guy's absolutely right. That's no kind of life.
That's
No,
awesome.
Raymond hunts like his family was murdered by deer. He's like he hunts with vengeance. He goes after those poor turkeys and deer, man.
I was gonna say turkey's more than deer.
Turkey, I know. It's like they owe him money or something.
Put your DEET on and cover your clothing with permethrin, brother. That's it.
I don't do that. I should, awesome. And I have it, but I don't. That's what's so bad.
Tell Eric Anger hi, and
I will.
Ask him if he went to any fun Pirates games as a resident with anybody. We may or may not have tied a few on. Too many at the Pirates game.
Too many on the Pirates game. I will bring that up. I will be in Elkins working this weekend, so
tell him hi. So
I will make it a point to bring that up. But again, appreciate that.
John, that was excellent, buddy. It was really
appreciate it, man.
Really, really good. Really, really good.
Thank you all. I'll be giving out a recap email, and then you can watch this again on YouTube if you need to. All right.
YouTube.